Okay, hello everyone. Can you hear me?
Yes, Professor.
Thank you very much. Okay, so I think it's the fourth lecture from our 2021 spring semester lecture series. And today I would like to share some knowledge regarding the correlative imaging of male genitourinary tumors. And I'm Min-Seok Soo. I'm research professor in Department Nuclear Medicine, and I have specialized for nuclear medicine imaging. Okay, I will now start. So this lecture has two major contents, which is the urinary tract malignancy, including the Renar cell tumors and the bladder tumor. And second part will be about the prostate cancer, which there has been an increasing interest also for our nuclear medicine physicians. Okay, so before moving on for the imaging, I would like to introduce about the anatomy of the urinary tract. So urinary tract is the body's drainage system for removing urine, which is made up of waste and extra fluid. So the urinary tract actually includes these two kidneys, two ureters, and a urethra, bladder, and a urethra. And for the kidney, this kidney anatomy is actually has a functional substances for parenchyma and also the Renar pelvis. And for the parenchyma of the kidney is divided into two major substructures, which is the outer Renar cortex and the inner medulla. So from the kidney parenchyma, the urine is made and it empties into the calyces and it moves on into the Renar pelvis and goes through the ureter, bladder, and urethra. So the disease originating from each proportion have somewhat distinct features. Sorry, I will just check for the chat. Okay. Oh, so sorry, but if you have any questions or comments in between the lecture, you can also give me some comments or questions in the chat. Then we can have a discussion at the break time or after the end of the lecture. Okay, so going on. So there is like distinct parts in this urinary tract. So diseases originating from each portion have somewhat distinct features. Firstly, there can be a tumor originating from the kidney, Renar parenchyma. And firstly, the most common malignancy is the renal cell carcinoma. And secondly, the most common benign tumors in the renal parenchyma is the angiomyolymphoma, and which is followed by the oncocytoma. And after that, when we go down, there are other distinct features which we call urocellular tumors. And the most abundant type in this urocellular tumors are the urocellular carcinoma, which is also known as a transitional cell carcinoma. And this TCC, transitional cell carcinoma, is mostly prevalent in the older patient. So we can engage with patient with a older age. And the location usually of this urocellular carcinoma happens, oh, sorry, I will move on to the, so yeah. Okay, actually, there seems to be some mistaken of the slide, but what I want to tell you was that the most prevalent location of the urocellular carcinoma is in the bladder. And like more than 90% of tumors arise from the bladder. And actually, the Renar pelvis and ureter is very less frequent place for the arise of the transitional cell carcinoma. So this is same, like there is a bladder tumors, which is urocellular carcinoma and squamous cell carcinoma and adenocarcinoma can be seen. However, the most prevalent is the urocellular carcinoma. Sorry. Yeah, I am very sorry. I have put a slide which was not updated. Sorry. So this is, I will actually update the slide in the online website. So please refer to that. And I really am sorry. So moving on to the Renar tumor. So before, when we review the CT or PET-CT image, there are some steps that we should check whether to do the differentiation of this Renar tumor. And Renar cysts are the most commonly encountered Renar lesions when you review a CT or PET-CT images. So it is important to firstly characterize whether the lesion is a cyst or not. And usually in the CT, like in our non-contrast CTs, lack of enhancement or very well-defined fluid components are the things that confirm the cystic nature of this simple cyst. And Renar cystic lesions are usually classified using the Bosniak criteria, which is a internationally recognized classification. And how to do this classification is you can refer to these example images. Usually in the hybrid imaging with FDG PET-CT, the simple Renar cysts are photopenic. And so these simple Renar cysts do not need PET-CT for characterization, and these do not require follow-up. However, like more than the classification 2, like 2F or 3 or 4, there are needs for further evaluation. So after excluding these 1 or 2 Bosnia classification Renar cysts, which can be referred to as a simple cyst, you can move on to look for the fat component. So if a lesion contains a macroscopic fat on CT, we can diagnose it as a angiomyolipoma, which is the most prevalent benign tumor in the Renar tumor. So we can use a house-filled unit, which is less than -20, which indicates the fat tissue. And if it is in the Renar mass, it is a reliable sign of this AML. And so since this AML is the most common benign solid mass, but however, when there is like, if you see not only the fat, but also if there is a calcification, we cannot exclude the possibility of the renal cell carcinoma. So not only the fat, but you need to see whether there is a calcification in that lesion. After excluding this AML, we can then move on to see whether this is really a tumor or not, like cases of infection or infarction. But in most cases, the patient history and the clinical findings can help you to make a right diagnosis. Like for example, if patient have an infectious condition, the patient will have some pain and signs, which regards to the pyelonephritis. And for the renal infarction, it usually results from the thromboembolism of the cardiovascular disease. And as in the right side image, in the CT, you will see a wedge-shaped attenuation decrease, reflecting the vascular perfusion territory. And in the later phase of this infarction, the kidney may move on to the atrophy. And in some cases, since the outer cortex may still enhance through the collaterals, so there might be a resulting cortical rim sign, which is in the right side image as a yellow arrow. You can see a cortical rim sign indicating a renal infarction. So now we have excluded simple cyst, AML, and the possibility of other infectious infection. Then we have to see whether this lesion is metastatic disease or lymphoma involving the kidney. So usually this metastatic disease or lymphoma is presents as multifocal, and bilateral lesions are normal. And diffuse renal infiltration with like lymphadenopathy will indicate a involvement from the lymphoma. So more importantly, there are some differentiating features because these tumors are firstly indifferent of the origin. So mainly there are some markers from the CT that may differentiate the renal cell carcinoma from the lymphoma is features of like absence of calcification and post-contrast homogeneous attenuation. And if there is absence of renal vein thrombosis, or if there is absence of obstruction in the pelvic calyceal system, these may indicate a lymphoma rather than renal cell carcinoma, since renal cell carcinomas can actually have a mass effect in the renal calyceal system, or pericalyceal system, or it may have calcification or renal vein thrombus. So these features, if you see like dilated calyces, then it might be more indicating the renal origin tumor rather than lymphoma involvement of the kidney. So now we have excluded some possibility of other lesions. So now we can move on to see the renal tumor, the renal cell carcinoma. However, before, there are also morphological type that we can use for the differentiation of the tumors. So there are two types actually. One is the ball type and one is the bean type. So ball type lesions are more common than the bean types, and it presents as a expansile masses deforming the contour of the renal cortex. And usually the renal cell carcinomas are the ball type, and other like AML and oncocytomas are also some common ball type lesions. Compared to that, bean type lesions do not deform the renal contour, and it is inside the kidney contours and the shape. So the shape of the kidney is preserved in this bean-type lesions. So actually, when you do the non-contrast CT, it might not be possible to differentiate the tumor lesion from the normal parenchyma. And usually these bean-type tumors consist of transitional cell carcinoma, metastatic lesions, or renal cell carcinoma with infiltrative type. And also renal cell carcinoma, which is originating from the medullary cortex, can be bean-type lesions. Okay, so I will now move on to the renal cell carcinoma. So renal cell carcinoma is the 6th most frequently diagnosed cancer in men, and for females, it is 10th most commonly encountered mass. And it has been increasing, and especially in a higher income settings. So usually the renal cell carcinomas are as morphologically bold-type lesions and we usually find this RCC lesions in the incidental findings, such as when we image for other reasons of the abdominal pelvic CT, or we can incidentally find it when we want to evaluate the spinal, like thoracolumbar spines. We can incidentally encounter its kidney tumors. The peak incidence is between 60 and 70 years, and the most common subtype of the renal cell carcinoma is clear cell carcinoma, and it is followed by papillary, chromophobe, or multilocular cystic carcinomas, which is quite not common compared to the clear cell type. So firstly, clear cell is the most common subtype of the renal cell carcinoma, accounting for 70% of all RCC. And these tumors arise from the renal cortex, and they are often expansile, like a bowl type. And it is very hypervascular tumor, and it shows, when you see an enhanced CT, it shows frequent heterogeneous feature, which is due to necrosis and hemorrhage or cystic components or calcification. So again, if we see a mass with both calcification and fat, and if it is very heterogeneous, we should consider the possibility of renal cell carcinoma with clear cell type. So the typical feature of clear carcinoma is because of its hypervascularity, it has a strong enhancement in this corticomedullary phase, which is around 50 seconds. However, this can be difficult to assess because the renal cortex also has a strong enhancement in this phase. So the nephrogenic phase, which is like in between more than 100 seconds, can be more sensitive phase for the detection of these lesions. Because in this phase, the renal parenchyma enhances very homogeneously than the tumor itself. So it might be more sensitive phase. Next to the clear cell carcinoma is papillary renal RCC, and it accounts for 10 to 15% of all the renal cell carcinoma, and it has very homogeneous feature and hypovascular. So in some cases, it can be quite, it may be hard to discriminate between the cyst and this papillary renal cell carcinoma. And chromophobe type account for 5% of all RCC, and they are very solid and sharply demarcated features. So it may be hard to differentiate from the second most prevalent benign tumor, which is the oncocytoma. And even when we see after the biopsy, when we see the histology of these tumors, this oncocytoma and the chromoprobe RCC share a very similar characteristics. And as you can see of this homogeneous and hypovascular or type, you may assume that these both tumor subtypes have relatively better prognosis compared to the clear cell types, which 5-year survival was known to be 80 to 90%. And there is a Renar medullary, the medullary carcinoma, which originates from the medullary cortex, and it is mostly limited to exclusively features in an adolescent or a young adult. So when you encounter a patient with Renar tumor in between 20s or who are in an adolescent, you may have to be in the first place some differential diagnosis of this Renar medullary carcinoma. And these are normally a bean-type tumor, and this tumor quickly grows to fill the Renar pelvis and invade vascular or lymphatic structures, having poor prognosis. So now we would like to move on for the staging of this Renar cell carcinoma. So staging Renar cell carcinoma is based on their size, position, and lymph node involvement. So for example, like stage 1 or 2, tumor is enclosed wholly in the kidney, and stage 3 tumors can actually extend into major veins or adrenal glands within the Geraltas fascia. And if we move on to stage 4, these tumors can invade beyond the Geraltas fascia and have distant metastasis. So why this is important, and our imaging or also FDG PET can have important implication to detect, for instance, stage 3, if whether there is a tumor thrombosis is also important, because whether there is a tumor thrombosis in the inferior vena cava, and if it extends into the chest above the diaphragm, actually there is a need for cooperation with the thoracic surgeon. So it is very important for imaging to actually indicate the extent of the tumor thrombus. And these image actually illustrates some example how the renal cell carcinomas spread. And approximately, it is known that 25% of the patient have metastasis at the presentation. As I have mentioned, that because of its hypervascular characteristics, the renal cell carcinoma has very hematogenous features of metastasis. And the common sites are lung, and which is followed by bone, lymph node, liver, adrenal, and brain. And regional lymph node for the RCCs are hilar or retroperitoneal lymph node. And when the lymph node goes beyond this, it should be considered as distant metastasis. Okay, so we have now seen the cell types of the RCC and some staging. And now we want to know what is the role of the FDG PET-CT, or what we nuclear medicine physicians can do for diagnosis or evaluation of the renal cell carcinoma. So it has been, firstly, there are, we have discussed from the previous lecture regarding the colorectal cancer, there are also incidental renal uptake can be encountered, or like not a simple cyst, but a complicated cystic lesions can be encountered when we do the readings of FDG PET. So actually, it has been estimated that more than 50% of RCCs are found incidentally on imaging, which is also from like, which FDG PET-CT has some portion. However, the most commonly encountered incidental lesion in the FDG PET-CTs are cystic, simple cysts. But there are also chance, like 5% or less of chance to encounter a more complicated or soft tissue lesion. And normally, if you see a mildly FDG, like in the image C and D, you can see a mild FDG-evid soft tissue lesion in the Renar cortex. And it is, it can actually, we can have a suspicion if we see this kind of lesion. And as you can see from the MRI, it has a corresponding heterogeneously enhancing soft tissue lesion, which indicates the renal cell carcinoma. Okay, so using FDG PET-CT, we can, the detection actually of the RCC, the primary region is quite limited because the kidney, the FDG itself is excreted through the urinary tract and it passes through the kidney. So characterizing the tumor inside the Renar cortex or Renar parenchyma might be quite limited. And also this Renar cell tumor has a natural characteristics of low glucose assumption. So like from this meta-analysis, they have shown quite limited diagnostic performance for the Renar region. However, this FDG PET-CT might have their efficacy for extra-Renar lesions, which have shown a pooled sensitivity and specificity of 84 and 91%. However, because of this limited use, actually, we in our institute also, we do not do like accounting for all the PET-CT cases, the RCC or renal cell tumor accounts like less than 1 to 2% in our institute. So there has been quite limited studies regarding the diagnostic performance of FDG PET. So like it may be hard to conclude. But interestingly, there are also some reports about the accordance between the FDG avidity and the cell type of this renal cell carcinoma. And normally, the high grade are clear cell renal cell carcinoma, or papillary cell type showed a high SUV, high FDG avidity compared to low grade, chromophobe, or like other benign tumors. So again, like AML and oncocytoma, usually in the PET-CT showed a very low FDG uptake compared to a high grade or papillary cell type. But still, because these two tumors are the most prevalent benign tumor, we should be careful for the diagnosis. And actually, for these tumor types, the CT can give you a great information. Like for instance, like for AML in the upper row, the contrast enhanced CT show a heterogeneous attenuation lesion with a very with significant fat attenuation in the lower pore, which indicates the AML. And at the lower enhanced CT, it demonstrates a hypodense soft tissue lesion with a some tiny calcification in the mid-pole, and it corresponds to, with a minimal FDG uptake, and it was confirmed as a oncocytoma. But there still needs some concern, like for the AML, from the previous report, which I have informed from this study, actually, it showed that it has a relatively low FDG avidity for angiomyolymphoma. However, other reports actually, there are some heterogeneous reports about the FDG avidity in the AML. So the FDG PET, like solely, it might not be possible for the differentiation of diagnosis between the malignancy and benign AML. And moving on, for the prognosis, there has been some paper that FDG avidity is related with the grade of the RCC. And also it is accordingly, because it is related to the grade of the RCC, it has a, the uptake has a prognostic implication. And this study showed that like SUV max of more than 10 can be indicated of a poor prognosis. And actually, as you can see, like in the left cases, the patient had a very low or equivocal uptake in the tumor. And actually, these patients showed a relatively long progression-free survival. However, like the next case at the right below shows a very intense uptake higher than SUV max of 10 and had a dissemination of the disease progression after 1 month. So there has been such a study that there is a significant difference in the mortality if you divide a patient using this kind of like FCV max of like in a high value of, in this study was the 10. And also the FDG PET-CT have shown a relatively good performance for detection of tumor recurrence. So compared with a conventional imaging methodologies such as CT or bone scans and also MRI, it showed higher sensitivity, specificity, and accuracy for detecting the tumor recurrence after the surgery or radiation therapy, after the surgery, actually. Okay, so we have seen that for the RCC, FDG PET has quite a limited role for the staging purpose. However, for the extra-Renar lesions, it can have some effect or some advantage compared to the conventional images. And this FDG PET uptake is indicated of the high grade and also the prognosis of the patient. And for the evaluation of the recurrence of tumor, this FDG PET-CT also can be used. And recently, there has been a change, like not recently, 10 years ago, there has been a change in the paradigm of the treatment of the renal cell carcinoma. Actually, it was started from this randomized clinical trial comparing the sunitinib, which is the receptor tyrosine kinase inhibitor. And it is known to inhibit the tumor angiogenesis and tumor cell proliferation. And since the RCC is known to be a hypervascular tumor, you can actually imagine this RCC might have good response to the sunitinib, like which can block the angiogenesis. And actually from the study compared to the interferon alpha, it showed a longer progression-free survival. So the current the treatment flow is like this, like for stage 1, to 3, you can do a nephrectomy and do a active surveillance. However, for stage 4, it may be indicated to go on for the sunitinib, like this TKI therapies. And so for these therapies, there has been a study whether the FDG PET can be useful for evaluation of the sunitinib treatment response. And this one study in 2011 reported that from 14 patients using the EORTC criteria found a metabolic response patient, partial response was acquired in 6 patients and stable disease for 3 and progression in 4. However, as you can see from the RECIST criteria, all the patients were actually in the state of stable disease except 1 for progression disease. So there is like using this different, using our metabolic criteria, we have found more patients which actually had a progressive, metabolically progressive disease after the therapy. And actually they compared the PMR and SMD group from the PMD, the progression group, and they have shown a significantly improved prognosis in the metabolically response or stable disease groups. So they insist that using this FDG PET as a treatment response can be useful as a criteria, treatment assessment. However, still, like this FDG PET has because of urinary expression, has very limited performance, as I have mentioned earlier. So there has been like other alternative tracer research for the tracer. And this study shows the ability of acetate, C11 acetate, can be used for the evaluation of RCC. And of the 20 renal cell carcinomas, in this here, they showed that 70% showed positive acetate uptake. And among these, 6 were negative in the acetate PET. However, from the 6, actually the 2 were like just a complicated cyst, which were not a malignancy. And other 4 were false negative cases, but still they had a high positive predictive value or high detection rate of 70%. And and so you can see that like from this 18 renal cell carcinomas, 20 renal cell carcinomas, as you can see here, 19 were actually clear cell and only 1 was the papillary. However, the papillary cell type, as you can see here, had high uptake SUV value and high SUV value of acetate uptake. So it is somewhat similar to the SUVs of FDG, like the FDG uptake was higher in the high grade or in the papillary cell type. So it might be quite relevant to the FDG findings too. Nextly, there has been a attempt to use PSMA, which is a novel tracer targeting the prostate specific membrane antigen. And actually this PSMA is known to be upregulated and highly expressed in the neovasculature of the solid tumors, including the RCC. And this study reported at 2016 showed that when you use a PSMA CT, it can have a better sensitivity and positive predictive value compared to the conventional CT for detecting renal cell carcinoma and also its invasion, like tumor thrombus in the inferior vena cava. And as you can see, like in this case, there was a RCC with IVC tumor thrombus in the IVC, which is a corresponding uptake in the PSMA image. However, additionally, this PSMA PET found a tumor thrombus extending into the lumbar vein, which is not actually seen from other like CT, CT or MRI image. Moving on, actually, because as mentioned, the PSMA is upregulated in the neovasculature of tumor, you might imagine that like sunitinib, like kind of the tyrosine kinase inhibitors, actually also targets the angiogenesis. So you can assume that PSMA-based imaging can be used as a treatment monitoring for this TKI treatments. And also, there has been one report recently that this PSMA PET-CT can have a good, can show treatment response of the cabozantinib, which is also another tyrosine kinase inhibitor. But still, like further studies is necessary to show this PSMA PET for new application of treatment response of TKIs. Okay, so for the first case, the 73-year-old male patient came to the hospital for the workup of incidental renal mass. Okay, looking again. There is a infiltrative lesion and solid mass lesion in the left kidney and upper pore area, and there is also a soft tissue attenuation along the renal vein, and also some in part in the IVC areas. So, and also there, as you can see, there are lymph nodes in the para-aortic or renal hilar areas. And from the CT also, they have, so, and some nodular region in the right adrenal gland, which was not some intermediate lesion, which can be adenoma or also a metastasis from the renal cell carcinoma. So from the image, you can see a RCC with venous thrombosis extending from the renal vein to the IVC, and also lymphatic metastasis and probable and possible metastasis to the right adrenal gland. So for the evaluation, the more further evaluation, PET-CT, FDG PET-CT was done in this case. And actually, from the image, you can see a like a relative hypometabolism, and also here might not be seen well, but there was a focal hypometabolic lesion in the right frontal cortex, indicating a brain metastasis. Elsewhere, the lungs were actually not demonstrative of metastasis, but the lesions in the right adrenal gland showed a high FDG uptake, so we could suggest a right adrenal gland metastasis. And also, there was an uptake in the right parotid lymph nodes, and also there was FDGability along the renal vein and some part in the IVC. Still, however, the RCC itself compared to the CT image was not that much discernible, actually. There are some point with high FDGability, but in some sense, it was not that much discernible from the Renar parenchyma, normal Renar parenchyma. So this patient was diagnosed as RCC with lymph node and RCC with renal vein and IVC tumor thrombus and lymph node and right adrenal gland and brain metastasis. And this patient have undergone resection of the nephrectomy for the renal cell carcinoma, and it came out as a high-grade renal cell carcinoma. However, the tumor type was papillary type. Still, the patient showed very infiltrative, invasive features, which is more seen in the clear cell carcinomas. So for again, FDG PET-CT has somewhat limited role in diagnosis of the RCC, but it can have its role for the depicting the extrarenal regions. And other agents such as acetate or choline can be used for evaluation of RCC. And also recently, the PSMA has been adapted because of its because of the high expression of PSMA in the neovasculature. And so in the future, it might be it can be used for the treatment response evaluation of the tyrosine kinase inhibitors. So this was about the renal cell carcinoma, and now I would like to move on to the bladder cancer, which is the 9th most common cancer. And like more than 60% of all bladder cancer cases and half of all the bladder cancer deaths occur actually in the less developed regions, which needs more focus for this cancer. The most common type of urocellular cell carcinoma is actually the urocellular tumor is the TCC, the transitional cell carcinoma, and the location, as I have previously mentioned, is most are in the bladder, like 97% are occurred in the bladder and less commonly in the renal pelvis and ureter. Typically it is a tumor of old age patients, and the average age is 65 years, and there is a prevalence more in the male than female patient. And like renal cell carcinomas or renal tumors, it can be also distinguished by its morphological patterns of papillary or non-papillary pattern. So this papillary tend to be very low grade, and it less invasion to beyond them. It has a less invasion. However, non-papillary tend to have a high grade, and it has a characteristic for early invasion beyond the mucosa. So further looking at here that this papillary, there is a papillary tumor type, and also there are some other type of sessile or carcinoma in situ, which is a non-papillary type of cancer. And also this like microscopically or from the images, it can be differentiated from the superficial to the invasive stage. So normally the superficials are like more like 70 to 80% are superficial tumors. And most of the superficial tumors are actually a papillary type tumors, and the sessile tumor or carcinoma in situ comprise of 30% actually. And also like 20 or 30% of tumors are actually invasive. Okay, so before defining the bladder cancer in the image, we need to know the normal bladder wall thickness. So the normal bladder wall has a mean thickness. From this study, show that it has a mean thickness of 2.76 millimeter when the bladder is almost empty, and 1.55 milliliter when it is distended. And the upper limit was shown to be 5 millimeter when the bladder was empty. So like when there is a bladder thickness more than this, can be actually, we can have suspicion about this kind of lesion. So like asymmetrical mural thickening should be viewed when we encounter with these lesions in the CT or like ultrasound. We should be viewed with suspicion. Okay, after for the staging of bladder cancer, actually it is interestingly that the CT is not able to distinguish the T1 to T3A. So like for these, actually the CT itself cannot distinguish, but MRI so has a superiority compared to the CT. And actually in some instance, it can actually distinguish T1 from T2 tumors on T2 weighted images. And one interesting point you might be in mind is for the prostate invasion. So there is three ways of prostate invasion, which is through the intraurethral pathway, or by extravesical, or by through the bladder neck. So like in this image, like for here, it actually penetrates by extravesical pathway and directly invades the prostate. So this can be indicated as T4. However, there can be a chance of tumor here and moving on to the urethra and then invading the prostate. So in this kind of intraurethral invasion of prostate, actually, this T4 is not indicated as a T4. And in this situation, actually, the staging of this situation should use a urethral cancer staging rather than bladder cancer staging. So you might, when you encounter this kind of lesion, you might be aware of how to actually define the T4 of the prostate invasion. So still, like CT has some limited performance for distinguishing the T1 to T3A. However, like MR or imaging studies can distinguish T3B and T4 in a good performance. And like, as you can see for T3B case, you can see a macroscopic invasion to perivascular soft tissue. And also for like in the T4 case, you can see a direct invasion into adjacent structure. And in this case, there is a direct invasion to the uterus. And moving on for the metastasis to lymph nodes, like if there is a lymph metastasis beyond the iliac lymph node, they are actually considered as a distant metastasis as M1A. And you can refer to what are the regional lymph nodes for the bladder cancer here. And actually the M1, distant metastasis, also divided into M1A and M1B. M1A, which is limited to the metastasis with only the lymph node metastasis. And because this M1A patient from the report showed a better prognosis compared to the M1B, this classes are distinguished in the bladder cancer. And these figure illustrates the normal spreading patterns of bladder cancer, and it abundantly involves lymph node followed by bone, urinary, or lung. For the PET-CT, FDG has a high FDG ability for the transitional cell carcinoma. However, also because of the urinary excretion route, it actually interferes the performance of FDG PET as to actually detect the bladder lesions. So there are very limited number of reports as like in the renal cell carcinomas. So although you can see from the meta-analysis, they have shown a pooled sensitivity and high pooled specificity of like 92% and 100%. However, there are like only two studies that were involved. So it is very limited number of studies. And so we need more studies to actually to seek the diagnostic performance. But there also has been some attempts to actually enhance the detectability of the bladder lesions by like giving a forced urination. So to overcome, here they use a furosemide to force a urination after the injection, and after the initial imaging, they give furosemide, and they do after the voiding, they have done the regional scan again. So like in this case, this case was a patient who had a chemotherapy and some suspicious recurrence. And as you can see, there are some equivocal foci in the bladder. However, could not be, it's not that demonstrable. And in this case, after the furosemide, you can see a foci uptake remaining in that same region, indicating the bladder cancer. So by using this method, they have shown that it can have a great performance for detecting intravesical lesions. Like in 12 bladder cancer patients, out of all 12 patients, they found they reported that they can show very this intravesical lesion. But however, also they have shown that in like if there is no uptake after this forced voiding, they have concluded as a negative case. And actually from the histopathological confirmation, it also came out to be a true negative. So they insist that this by voiding method can be used for the detection of bladder cancer. And also there has been another attempt by using a early dynamic image. As you can see in the dynamic curve here, there is a more FDG uptake in the early phase. So using, because like bladder is filled out after the FDG passed through the kidney and ureter. So like early FDG uptake in the tumor is higher than the bladder wall. So like this early dynamic image can be helpful for detection of the bladder cancer. So they actually, by using this early dynamics, they found that sensitivity for detecting the lesion was up to like 85%, which is comparative for the standard method, which is 57%, and it was significantly higher. And the uptake SUVs in this early dynamic PET SUV max was, they reported that it was correlated with the invasiveness of the bladder cancer and also the histological grade and the tumor size. And for the bladder cancer, the FDG PET CT can be used for the staging. And this meta-analysis showed a sensitivity and specificity for 57% and 92%, which is relatively low sensitivity for detecting the lymph node. And also for the distant metastasis, it showed a more higher specificity of 89 and sensitivity of 82%, which indicating a good performance for detecting the metastatic lesions. And this FDG PET CT can also be used for the evaluation of the recurrence. But more importantly, what in this study, what they have reported was that it can give a change in the management in up to like 40% of cases. And what also they have shown was that this FDG positive and negative in the recurrent regions are indicative of the prognosis of the patient. So like patient with have a positive negative FDG uptake in the recurrent lesion were indicative of good response, which has a significant difference in the overall survival. And like in Renar tumor, there is a attempt using a alternative tracers rather than the FDG PET. And so when you see the normal biodistribution of this C11 acetate and the C11 choline, you can firstly see that there is a high uptake in the pancreas for the acetate and some relatively higher uptake of kidney in the choline PET. However, the interesting point and important point is that there is no uptake actually in the bladder. So they implicated that they suggested that this choline or acetate PET can be used for detecting bladder cancer, and they did a comparative study showing a equivalent results, and which is had like better sensitivity and specificity compared to other like FDG PET or CT imaging for detecting the bladder tumor, intravesical bladder tumor. So for the second case, the 69-year-old female patient came to the hospital because of gross hematuria and for the workup. And as you see from the image, you can see a very papillary, small papillary type tumorous lesion in the posterior wall of the bladder. However, as you might imagine from the PET, actually it is hard to distinguish the tumor lesion in the bladder itself. However, it is the tumor in the left external ilia is well seen. So like, as you can see, like for the detection of primary lesions, actually the FDG PET-CT has some limitation. However, detecting other lymph nodes or extravesical lesions, it might have some good performance for detecting these lesions. So this patient underwent transurethral resection of the tumor and had a papillary urocellular carcinoma, which had a high grade. Okay, so I think we can now have some break, and in between that, if you have, do you have any questions or comments regarding the lectures of urinary tract tumors, renal cell carcinoma or bladder cancer? So if you have any, or if not, we can have a 10-minute break, and we will see 10 minutes later. Thank you very much. Okay, now I will move on to the prostate cancer. And okay, so the prostate, so you can hear me, right? Okay, so the prostate is accessory gland of the male reproductive system, and it is a ejaculate. It has a function of the it has muscle-driven mechanical switch between the urination and ejaculation. And anatomically, as you can see here, it is found below the bladder and with the urethra passing through it. Histopathologically, it is found that the prostate has 4 distinct regions of zones, so which has some different features of also tumors which arise from these distinct zones. So you might be in mind of this. What are these distinct zones? So for the first is the peripheral zone, which is the largest part, and it comprises of 70% of the prostate. And it is actually, it is the most common site for the prostate cancer, as it is the most largest part. So also 70% of all the prostate cancer arise from here. And since it is in the peripheral side, like if the tumor actually exceeds the size of 0.2 milliliter, actually it can be detected by the digital rectal exam, the DRE. And next is the central portion, as you can see in the center here, and it lies in the base of the prostate, and it's behind the transition zones, and it and it surrounds the the ejaculatory duct, and it comprises 25% of the prostate. And the interesting point is that it is relatively immune to the cancer. So the prevalence of tumor in this central zone is quite less. However, if there is a cancer arising from this central zone, it usually have very aggressive features. The third is the transitional zone. You can find in here, the C is the transitional zone. And it is it actually covers the urethra. The prostatic surrounds the prostatic urethra. And it accounts for less than 5% of the normal prostate gland. However, when there is a BPH, actually the enlarging part is this transitional zone. That is why if the patient, like elderly patient, have a BPH, there is a problem for the urination, voiding because it actually squeezes the prostatic urethra. And 25% of the prostate cancer actually arise from this transitional zone. But however, this cancer from this transitional zone show much less capsular penetration or other adjacent organ invasion because the boundary of, because it is in the inside and there are boundaries of the fibromuscular zone and also the peripheral zone. Without extruding these zones, this cannot, these zones actually act as a barrier, barrier for cancer spread. So normally it is known to be less invasive in the tumor in this transitional zone. And so, comprehensively, you can see that most cancer lesions occur in the peripheral zone of the gland, and fewer occurs in the transition, and almost none of the cancer arises from the central zone. However, for the benign prostatic hyperplasia, BPH, it is mostly occurring in the transition zone. Okay, so the prostate cancer now is the second most common cancer globally among the men. However, the incidence and mortality quite vary between countries. Like in the Western countries, it is quite high, but like in our Korea or other Eastern Asian countries, the prevalence is relatively low compared to the Western countries. However, due to the change in like food intake and environments, there is an increasing prevalence also in the Asian territories. The prostate cancer, the adenocarcinoma, actually is the most common type of prostate cancer, although there are other types like transitional cell carcinoma, and also like neuroendocrine tumors can arise from the prostate. And for the prostate adenocarcinoma, there are two important mutations, which is BRCA1 and BRCA2. And they have been associated with more aggressive disease and poor clinical outcome. And also this prostate cancers usually show relatively slow growth rate. And how to actually diagnose is firstly, the most important is the PSA, which is the prostate specific antigen. So this PSA is secreted by the epithelial cells of the prostate gland. And actually the function of the PSA is for the liquefies of semen. And so to actually allow sperm to swim freely. However, it also can be excreted to the serum in very small amount. And this can be an indicative of some pathologic process in the prostate. So this PSA test is a screening test used for the prostate cancer. However, like the PSA levels may be alleviated due to reasons other than cancer, including like aging or inflammation or BPH or other conditions. So like also biking can actually make an increase in the PSA. So when there is an abnormality in the PSA result, there needs a further evaluation. And usually we do the imaging studies, like the sonography can be used as a conventional method, but usually nowadays the MRIs are more widely used. And there is a reporting system named as Prostate Imaging Reporting and Data System. The PIROTS are a assessment category determination, and it actually determines the likelihood of the clinically significant prostate cancer, like which can be defined as tumor, which is higher than Glycemic Score 7. So detecting this tumor and making a category is the purpose of the PIROT. So, however, what you need to be in mind is actually this assignment of the PIROT, and their assessment category is actually differs where the central focus of the tumor is. So for the peripheral zone tumors, this diffusion or ADC are the standard choice of the imaging sequence to assign the PIROT. And for the transitional zone tumors, the T2 weighted images are the standard sequence. So for evaluating the tumor using the MRI, it is actually important, vital, to identify where the focus of the lesion is. So this is you can refer to the examples how to determine the scoring, and it is scored as a 5 categories: 1, 2, 3, 4, and 5. And when it gets higher, it is more indicative of a malignant lesion. And also when reporting, when you see the reports, like MRI report of like PIROTs, you can see like these kind of abbreviations of AS, TZ, and PZ. So you might wonder what they are indicating. And so these are the centers of the focus and what radiologists, the sector map that radiologists are using. And they, based on the PIROT version 2, they employ 39 sectors. So like 12 in the base and 12 in the mid portion because it is on each side, and 2 for apex, and 2 for seminal vesicle, and 1 for urethral sphincter. So total, it is divided into total of 39 sectors. And then like you can refer as there is a PIROT score of 3 in the anterior fibrous muscular stroma, and like AS lesion in the mid portion. Then you can imagine the location of the tumor. And after assessment and assigning the PIROT score, then there is this table summarize what you should do. So these are some suggested management plans. So like for PIROT 4 and 5, there is more chance of malignancy, so biopsy should be done. And for 3, actually, it depends on the clinical situation or significance. But for 1 and 2, actually, there might be more chance of benign lesion. So just a follow-up using the PSA can be relevant. But for now, so if we have seen a lesion which has a PIROT score of 3 or more, like 4 and 5, we have to do the biopsy. So the most commonly performed biopsy is under ultrasound guidance. So during the procedure, like biopsy needle is inserted through the rectum, and it gets a tissue, a small sample of tissues, and it gets the tissue from this like 12 core. And so this prostate is divided into this 12 cores, and for each they get the biopsy samples under the ultrasonographic guide. However, like you may imagine that there is a chance when you do this kind of standardized biopsy there is a chance of underdetection of higher grade tumors. Like there is a chance of
না জেসমেন্টকে অন্য ডিপার্টমেন্টে ওর এক্সপোজার দরকার আছে তো পিএমও হয়ে গেল আর অন্য কিছুতে এক্সপোজার নাই এটাই মুশকিল অনেকের নাই
pardon?
জেসমেন্ট পাপড়ি
Do you have a question, Dr. Fatima? Okay, I will move on. So there is a high chance of underdetection, like 30 to 45% for if it's high. So, like for example, if the lesion is in the anterior part, let's see in the anterior part, actually it is hard to get through by the rectum. It is hard to do the biopsy in this anterior site. And secondly, if it arises from the midline, and there can be a undersampling due to avoid the urethra. And also, like apex lesions are often inaccessible because, like by this transrectal route, it might, like apex might be not inaccessible. And for the lastly, like cancers in this middle of the sectors, actually it can be neglected and the biopsy can miss this kind of lesions. But also, what the other problem is that there is a over detection of low-grade tumors. Like because you do the biopsy for every this 12 lesions, if there is a benign lesion in the K or like low-grade tumor in the K, it should be diagnosed. And like, although there are evidences that for low-grade tumors, it is better to do the active surveillance, but because you have already confirmed a tumor there might be a over-treatment given to the patient. So there has been an alternative attempt using a diagnosis based on a MRI targeted biopsy. And there in 2018, from the precision trial, there has been a report of the efficacy of this MRI targeted biopsy. So from the precision trial, 500 men with clinically suspected prostate cancer were randomly assigned across multi-center to undergo MRI and with or without targeted biopsy or conventional TRUS biopsy. And the result was interesting that 28%, like here, 28% of the patient in the MRI targeted group did not undergo biopsy because the result of MRI was negative. And so actually, MRI with or without targeted biopsy was non-inferior to the conventional standard biopsy. And actually, from the confidence intervals, it actually showed a superiority compared to this TRUS biopsy. So overdiagnosis of clinically insignificant lesions, insignificant prostate cancer was significantly reduced when we applied this MRI targeted biopsy. So now there is a paradigm shift using the MRI guided biopsy for then the conventional like TRUS biopsy. So now from the biopsy, you have acquired a pathologic report, and you might see a pathologic report. Like this is a pathologic report from the conventional standard method of 12 core biopsy. you may see a report like this, like 3.4, like Gleason score for each course. So now you need to understand what is the Gleason score. So Gleason score is used by pathologists to grade prostate cancer. And it is if the cancer cells and their growth pattern look very abnormal, like it is graded at 5. And according to their pattern and abnormality, it is graded from 1 as a normal to 5 as very abnormal. And the Gleason score is the sum of the two most prevalent patterns, primary and secondary patterns. So you can, for example, if the Gleason score is written as 3 plus 4, it means that the most of the tumor is in the form of grade 3. And the second most common are the grade 4. That means 3 plus 4. However, you can imagine the 4 plus 3 means that the most of the tumor is grade 4. And the second most common or most malignant grade is 3. So you can think that normally 4 plus 3 might be more aggressive than 3 plus 4, although the score, Gleason score is same as 7. And also because the score, the highest score for each pattern is 5, the Gleason score cannot exceed the 10, and it is the highest score. So you can think, so this Gleason score actually indicates how quickly the tumor grows. And in 2014, the International Society of Urological Pathology released a supplementary guidance and revised this Gleason score and made a cancer grade groups. So like these Gleason scores were reorganized as a grade group. And as I gave you an example, you can see that although it is the same Gleason score 7, it was divided to 3 plus 4 and 4 plus 3. And as you can think that 4 plus 3 has positioned as a high grade group. Okay, so after you get this result, the prostate cancer staging should be done actually comprehensively, including the result, not only the T staging, but also the result of PSA and grade groups, which was mentioned earlier. This grade group should be also included. And when either PSA or grade group is not available, grouping actually should be determined by T category or like either which is available. So it is quite different from other cancers, which is solely determinant on the TNM staging, but this compromises all other important informations of PSA or group grade. And for the prostate cancer, the T stage, it is actually the T1 stage is only concerned in the clinical situation. But after the resection, radical prostatectomy, this T1 is no longer considered, and the pathologic status is only stage after T2. And when this tumor extends through the prostatic capsule, it is classified as T3, and when it invades the adjacent organ, like other tumor, it is classified as T4. And these are like green are the regional lymph nodes from the prostate, and it is known as pelvic, hypogastric, sacral, and iliac nodes are defined as regional. And if it exceeds this portion, it should be regarded as distant metastasis. And the most common sites of the distant metastasis are actually bones, and followed by lymph nodes or lungs at the later stage. So before studying there actually the FDG PET is used for the evaluation of the prostate cancer. And before that, we need to know what is the normal uptake SUV in the prostate. And one report actually showed that the mean SUV in the prostate was 1.3 and average of SUV max was 1.6. So in another study reported that when you see a focal prostate uptake, if it exceeds SUV max of 6, there may be more chance of malignancy. So you should do a biopsy for this kind of lesion with more than SUV of 6. And another point that they have pointed out was among these malignant lesions, like lesions with higher Glycemic score had higher SUV values. And another study from 2014 recommended how to deal when we encounter with this kind of incidental prostate uptake. So the conclusion can be summarized as like if you see a focal uptake and if it is co-registered with the calcification, actually there is more chance of benign lesion rather than malignancy. However, if the focal lesion is in the peripheral zone and it's without the calcification, there might be a high chance of a tumor or malignancy. So PSA measurement is necessary in this situation. However, still, the diagnostic performance for the FDG PET for prostate cancer are limited. And the widely accepted fact is that because of the urinary excretion can interfere, and also prostate cancer itself has a lack of glucose metabolism, it is limited for the evaluation of the prostate cancer patient using FDG PET. However, one study actually reported that when we limit the patient, include the patient with a elevated PSA level, there is quite relatively high potential to detect a cancer, especially in the peripheral zone. So, and it can be applied in some patients with high PSA level. So from the report, we can actually summarize that there can be a chance of relatively high FDG avidity if the patient have high PSA or the tumor has a poorly differentiation or high grade like stage with a Glycemic score more than 7, or in the patient who has a castration resistant prostate cancer, or also not reported, but size also have a great effect in the FDG uptake. Okay, so the 60-year-old male patient was, because of the elevated PSA of 7.8, done a workup. And as you can see, you might have passed through. Do you see the abnormality in the prostate? Okay, I will go again. Sorry, it's quite fast. Okay, so the problem was shown here in the transitional zone. You can see here, there is a change in the T2 signal, like low signal intensity lesion in the T2 weighted image, and which indicating a PIROD score, and the lesion was more than 3.4 centimeters, so it was indicative of a PIROD grade of 4. And as the tumor focus was in the transitional zone, actually the standard sequence for evaluating this lesion was the T2 weighted image. So this patient underwent a biopsy, but before that, the patient had done a PET CT for evaluation of distant metastasis or other, if there is a other lesions. But there was no. However, for the prostate lesion, as you can see, there is no demonstrable uptake in the alleged lesion, which was depicted in the MRI. There is actually no demonstrable lesion in the prostate. Okay, the second case is 88-year-old male patient and had an elevated PSA 114.4. And this patient, because of the elevated PSA, went on for the MRI evaluation. And as you can see, there is a change in the ADC, and also in there is a change in the diffusion and ADC maps, like in the low signal intensity and high signal intensity lesions are seen in the peripheral zone, and also in like this lesion extends to the peripheral to the transition zone. And because the tumor focus is in the peripheral zone, the PIROT uses the standard sequence of the ADC or diffusion map as a standard, and this lesion was also classified as PIROT 5, and so which needs a biopsy. And before the biopsy, patient have done a FDG PET-CT for other, like lymph node or distant metastasis evaluation. And this patient had no other lesions, but in the prostate primal lesion showed a high FDG uptake in the lesion, which was also corresponding to the depicted lesion in the MRI. So from the biopsy result, the first case was a ADC from the transition zone, not the transition zone, and the size was 1.4 centimeter, and PSA level was 7.8, and Glycemic score was 4+3. And second case was a ADC, which was in the peripheral to transition zone, and size was bigger, and the PSA was 114, and Glycemic score was 4+4. So you can imagine the PSA level or Glycemic score or the size of tumor will be some indicator we can assume for the high SUV or high FDG ability. And for the lymph node metastasis, it has been reported to have an equivocal performance compared to the CT. And however, for the bone metastasis evaluation, it is reported to have a limited performance because usually the bone metastasis of the prostate cancer are mainly osteoblastic. So like here, like bone scans have very high uptake in the acetabulum bone metastasis. However, in the PET, corresponding lesions in the CT, you can see a sclerotic lesions. However, the FDG uptake was relatively mild. So so evaluating bone metastasis can be limited just using the FDG uptake. But like when you see it comprehensively with the corresponding CT, you can actually you may find out the bone metastasis too. However, there is also a report that when evaluating the treatment response, the FDG PET can be more useful compared to the bone scan, since this osteoblastic lesions remain, although there is a therapeutic response. And for the recurrence, it is considered that the FDG PET can be useful in reassessing after the definitive therapy. And also, actually, this might be more useful in the patient which had a higher Glycemic score of the primary tumor. So like in these cases, it were like the recurrence was well indicated and detected, and these patients all had like high PSA and high Glycemic score in the initial staging. Okay, but still, FDG PET have a, as mentioned, limited value because of the urinary uptake, because it is in the route of the urinary excretion. So there is like various other PET tracers, and I think this prostate cancer has the most variable availability of imaging agents for nuclear medicine field. So they use quite different mechanism of action, like FDG for glucose metabolism, sodium PET for bone matrix and bone metastasis, and choline for membrane metabolism, and like more novel tracers like PSMA targeting agent or fluciclovin, which targets the amino acid transport. Or like recently, there are some attempts of using dotabombesin, which is a GRPR receptor binding agent. And also, since the androgen is the source of this prostate cells, targeting this androgen receptor has also been used for prostate cancer imaging. So for the first, choline PET is agent targeting the increased cell membrane metabolism. And here in this study show that choline, the SUV max of the choline PET from nevertheless, whether it is the focal or multifocal, it showed a more higher uptake compared with the benign lesion. So, and the diagnostic performance of the choline PET showed a sensitivity of 59% and specificity of 92% for the patient after the for detecting the lesion after the biochemical recurrence. And in the head-to-head comparison with the FDG PET, actually it showed a better performance for detecting more patients. And also not here, but compared to the bone scan, it also had a higher performance for detecting lesions. And more importantly, because applying this choline PET led to a change in treatment in 41% of patients. And so comprehensively from the reports and reviews, the choline PET is useful as the first imaging examination for biochemical recurrence. And like in between the PSA level of 1 or like more than 1, it can be a very useful tool. Okay, the fourth case, a 68-year-old male patient had a prostate cancer and Glycemic score of 4.4+4 and had a surgery and hormone therapy. However, from 2015, there was a slow increased alleviation of PSA level. So to see whether there is, because it is a biochemical recurrence, to see the focus, they have done like bone scans or CT images. However, they were not, the bone scan didn't pick out a recurrence. However, when you see the choline PET image, you can see some focal uptake in maybe the retroperitoneum area. So we have, and looking at the transaxial image of the choline PET, you might have seen some uptake, discernible uptake in the left supraclavicular lymph node areas, and also some discernible uptake in the retroperitoneal and the retrocavar or paraparotid areas. And also some lesion in the pelvic cavity. So this patient was diagnosed as recurrent in the lymph nodes mainly. So this patient now is undergoing for the chemotherapy using the Taxol-based chemotherapy. So colon PET can be a, now colon PET is actually the only alternative agent that is approved for usage like in biochemical recurrence of prostate cancer in Korea actually. But there are some ongoing studies regarding the gallium like PSMA targeting agents. But for now, it is the only approved agent in Korea right now. Yeah. And the next is the fluciclovin, which is known as FACDC, is a fluorescence labeled, fluorescein 18 labeled amino acid analog that can actually targeting the amino acid transport upregulation. And you can see from the biodistribution, and it actually differs from the choline or FDG. As you can see here, actually the kidney uptake is negligible for this fluciclovin, and also the bladder or urinary tract is not that much prominent from this fluciclovin PET. And also the thing is, it is actually approved by the FDA and European Commission. So it can be used for the clinical purpose in that countries. An interesting point is when you see the dynamic curve of this fluciclovin, that the great difference between like muscles and the tumor is achieved at the earliest time point. So the scan time point is very early at like 3 to 5 minutes after the injection. So like patient come and prepare, and after the injection, they do the imaging at 3 to 5, like after 1 minute, and then for the 20 minutes. So the imaging time will not be longer than 30 minutes. So it is very short compared to other like FDG or PSMA agents. And as I mentioned, this has already got the FDA approval, and several studies were reviewed for this FDA approval. And this is the one of the study that was reviewed. And in this study, they compared this FACDC with the colon PET, and comprehensively, the fluciclovin provided a statistically significant better performance in terms of lesion detection compared to the choline. And recently there has been a clinical trial after the approval, which is named as LOCATE trial. And it is using fluciclovin in patient with a rising PSA, which is a biochemical recurrence after the initial prostate cancer treatment. And it is an open label, multi-center, and single group, and phase 4, because it is already approved agent. It is a phase 4 trial. And the result were show that it has a higher, it can actually, okay, so this is, so firstly, you can see this representative image. So the case was a 77-year-old man with a biochemical recurrence after the radical prostatectomy. And the Glycemic score was 3 + 4, and PSA was 1.38, which is not that much high. So because of, however, because of increasing the PSA level, although it is like 1.38, they have done abdominal pelvic CT and bone scintigraphy. However, you can see in the CTs, they could not find any lesions that were indicative of tumor recurrence. And however, and also in the bone scintigraphy, they could not find. However, when you see the scan of the fluoxetine, they have found a focal lesion here in the external iliac lymph node, and also a focal bone lesion involving the right ileum. So, which was not actually shown in the other conventional images done priorly. And so the beauty was that for the pre-scan, using the bone scan or the CT, the management plan for this patient was to do the whole pelvis salvage therapy, because there was no like focal point that were there were no focus to be the reason for the alleviating the PSA level. However, after the fluoxetine, because they have found this focal lesions, which is causative, they have changed the therapy plan to giving the ADT and only the therapy to the prostate bed salvage therapy. So actually the interesting point of this study was that using the fluoxetine, they have found like 57% of patients were detected. So, and also like more than 95% of patients had a change in the management after the scan. And the most frequent major changes were from salvage or non-curative systemic therapy to watchful waiting, or from this systemic therapy to salvage therapy, or from salvage therapy to non-curative systemic therapy. So there was some change. And some interesting point was that the detection rate actually had increased proportionally to the pre-scan PSA. So if the PSA level is high, the detection rate gets higher. But one thing should be seen is, although lesser than the PSA grade 1, there still is like more than 50%, near 50% of lesions were detected, although it was in lower than 1 or 2. Moving on, more recently, there has been a new tracer that has acquired FDA approval, which is Psma targeting agent, the gallium-68 PSMA 11. So the PSMA actually is a prostate-specific membrane antigen, and it's a type 2 membrane protein, and originally characterized by the murine monoclonal antibody. It has a function of signal transduction or neurotransmitter interaction or receptor functions. And this PSMA are actually different from the PSA, because PSAs are actually a secretory protein. But more importantly, the PSMA expression seems to be inversely related to androgen levels. Actually, this was reported from some experiment from cell lines with different states of androgen deprivation. And this PSMA activity in the prostate cell lines increased as cells became more androgen independent. So this can be a very important point that PSMA can be applied also in the castration-resistant patients. So there has been attempts to target this promising membrane protein. So the most widely investigated and well-established tracer is the PSMA 11, which is now FDA approved as gallium-68 PSMA 11. And it has a strong binding affinity for PSMA, and it can effectively internalize into tumor cells. Also, it showed a superiority than conventional imaging modalities in biochemical recurrent patients. So you can see the normal distribution first, and there are like, firstly, high uptake in the glands and in the liver, spleen, and kidney and bladder shows high uptake. However, like the detection ability was quite surprising that like this patient had a PSA level of 0.01. However, there was a PSMA uptake was quite high in the inguinal or external ilia lymph node, which was later confirmed as the metastatic lymph node. So from these prior first studies, this gallium PSMA showed a potential of high detection rate, even at a low PSA level. So from these results, there have been like 2 studies actually were mainly reviewed for FDA approval. And one is this study. And this trial actually enrolled 635 patients who had rising serum PSA levels after initial prostate surgery or like radiotherapy. And when there is a biochemical recurrence, they were enrolled, and comprehensively in patients with like positive PSMA PET, local recurrence or metastasis were confirmed in 91% of cases. And this trial so insisted that gallium-68 PSMA 11 can detect sites of disease in patients with this biochemical recurrence. More importantly, you can see that there is a trend of when there is a higher detection rate or higher positivity in the PSA PET when the PSA range is higher. However, although below like 2, still the detection rate is still high for the PSMA PET. And another recent study is a prospective single center like comparative study, which compares the gallium PSMA to the fluciclobin FACBC. And as you can see, it enrolled 50 patients, and the primary endpoint was the comparison of the detection rate. And the PSMA showed a significantly higher detection rate of 56% compared to the 26% of the fluciclobin. So they insist that the PSMA should be the image of choice when there is a biochemical recurrence. And as you can see, like mostly overall there was a significant difference, but the more significant was in like depicting the lesion in the lymph node or bone and other extra pelvic lesion. But like for the prostate bed lesions, the performance detection rate was similar to the FACBC or lower. And it could be since this PSMA, as you have seen from the biodistribution data, there is a bladder uptake, quite significant bladder uptake, which may interfere the prostate bed evaluation compared to the fluciclobin. So, and more recently, as F18 has the advantage on gallium-68 for its availability and relatively longer half-life, attempts were made using F18 labeled PSMA. And as you can see from the biodistribution study from the PSMA 1007, and you can see that there is very minimal urinary excretion. And like at the time point when we usually do the image, like 60 to 80 minutes, there's like quite no non-urinary uptake and also in the bladder. So there is a high chance to detect the prostate bed lesions in using this PSMA F18 labeled PSMA. But however, so this retrospective study showed that there was, which included 100 patients, showed 95% showed at least one pathologic findings on this PET-CT. And although like the PSA was lower than the 0.5, there was like more than 86% of the patient were detected with a recurrence, showing its promising result. However, there are some concerns because there has been reported that PSMA can have an ability to detect more lesions. However, these lesions may end up as a false positive. And these pitfalls and the most prevalent pitfall lesions were the cervical, celiac, or sacral ganglia. And interestingly, in the ganglia, there is a PSMA uptake. So this was the most prevalent pitfalls that were detected through the PSMA F18 label PSMA. So like the author from this article insists that when you read a F18 PSMA 1007, you need to be have some training for like emphasizing and to know these pitfalls. Okay, so these are some various PSMA agents, and these might be following this PSMA 11. These other tracers might be introduced to the market, and PSMA 617 is actually a ligand that is widely used for the lutetium labeling and for the therapeutic use. So there are many other tracers now available for imaging the prostate cancer, which is FDG, choline PSMA, or sodium or fluocyclovine. And these choline FDG, like these all can be now used in clinically in like USA because of FDA approval, recent FDA approval. But like it may differ from country to country from their availability. And you, to apply these images, you might need to know their characteristics and their role. But like comprehensively, in summary, it is known that mostly there has been reported that PSMA had a better detection performance for compared to other imaging agents. But like fluocyclovine, because of its non-bladder uptake, it might have better performance for detecting intrapelvic lesions or prostate bed lesions. And another point is that there is significant difference in the imaging protocols. Like for C11 choline or fluocyclovine, it can be very fastly imaged. So the patient need very short time for in the hospital. However, like other tracers need more time for the uptake, which needs a more delayed imaging protocol. Okay, so these might be some summaries of each imaging agent and their biodistribution. So the fifth case is a male patient with 80-year-old male patient who has a prostate cancer and done surgery and Glycemic score of 4+5 and had a hormone therapy, but because of the bone metastasis, again in the thoracic spine, the patient changed added the Taxol-based chemotherapy in 2020. However, after applying this Taxol-based chemotherapy, the PSA was stabilized at 2019 and 2020. However, there was some slow. Firstly, slow elevation, but like lately, very sharp elevation of PSMA was reported. So firstly, we have done the bone scan to see whether there is like change in the known, the thoracic metastasis. So compared to, yeah, I think I have to put a same bone scan. However, so this bone scan was done at 2020 March, and this was done when it exceeds like at July, and there was no significant change. Only some subtle change in the T6 spine was shown, so not indicative of the tumor progression through the bone scan. So we additionally done the colon PET for the evaluation. And actually we have found like more lesions in the left scapula or lesions in the T-spines, like were actually visualized by the colon PET. And also in the lumbar spines were seen. So more newly appeared bone metastasis was confirmed using this colon PET compared to the bone scan. So this patient went on for the chemotherapy and for the thoracic lesion, some lesions in the lumbar spine for the salvage radiation therapy. However, after that, still there was an increase in the PSA level. And as you can see, when the PSA level reached 41.7, there was a significant uptake yearly, which actually was shown in the colon PET, but now seen after like 3 months. So this patient more underwent PSMA imaging at the time point when the PSA was 41.7, and as you can see, there were more metastatic lesions visualized, and which seemed to have very progressive tumor. So now this patient is preparing for a clinical trial for the treatment of this metastatic prostate cancer and like MCRPC as an MCRPC patient. So as I have mentioned earlier, we are now ongoing a clinical trial for adapting a new PSMA agent, which is named as NGU, also targeting the PSMA. And we have actually recently published an article for the head-to-head comparison study with NGU and PSMA 11 in the same patient. And now we are in the phase 1 clinical trial, and we have end up for the screening. And after that, I think we might move on to the phase 2 and 3 and for the clinical approval. Okay, so thank you very much. And this might be the end of the lecture. Do you have any questions or comments?
Yeah, I have some. I'm just wondering, you follow the US FDA about PSMA?
Okay.
Because PSMA, I think, started in the Europe. I mean, many years, probably like almost 10 years, probably. And
Yeah.
you only follow the US FDA, not the Europe or something like that. I mean the question is why don't you use PSMA now? Yes, that's probably the question.
Like what sorry, I didn't understood the question. So
yeah, the question is the PSMA started in Europe like 7 years ago, but it only approved by the US FDA last year.
Yes.
So the question is, in Korean, you follow the US FDA? So, right?
Actually, if there is if it is passed through the European Commission, actually we can apply it. There is some way to apply the PSMA agent as a but still there needs a company which need to bring this agent to our country, and also there were none. And so actually the gallium PSMA 11 cannot be used in Korea right now. So we are doing our own clinical trials to get our Korean produced PSMA agents right now. So actually in Korea, we have to pass through the Korean FDA. So although the agents have passed FDA or European Commission, it cannot be readily used in Korean. So that's some limitations right now. So I think Malaysia or other country might have a lot more experience than me for this PSMA imaging. So I think if you can share some, it might be also helpful for us.
Yeah. Well, because I'm just surprised that because I live in Thailand and we have PSMA like 3 or 4 years now, but we have different policy. I think we didn't follow the US FDA that much, yeah, something like that, and we don't have choline as well. I think for like 4 years we only do PSMA for the prostate cancer.
I think that might be a very good for us. It might be good actually. I think for rapid advance, it might some regulation actually it can interfere our advance. So actually in Korea, everything is quite delayed. Like for the therapy, we now actually have started the lutetium PSMA therapy for the first time as a clinical trial. And also Lutathera was recently applied in here also. So we are quite a late follower for this novel targeting agent.
Yeah. And I'm just another question. So you have in prostate cancer in your practice you do choline PET first.
So if there is a if it is suspicious of biochemical recurrence, we cannot. The only available imaging agent right now is the choline PET. So that's our choice right now.
Yeah, so FDG is like the second choice for the PET, right?
Yeah, but normally I think the FDG PET is not used widely.
Okay, okay. And the cost between two different tracer is it different that much?
No, it's actually not different that much. And
The-
also the patient, because we are covered by the insurance for the cancer patient, they only give like 5% of the total fee for, so actually it's not that much different for us and also for the patient.
Oh, that's nice. So it's covered by the health insurance for
Right,
the
yeah.
PET. Oh yeah, for I want to share something because in Thailand the PET scan did not cover by the health system. Yeah, but we have a few criteria for the official officers. Yes, just only that group. So in normal patient, it's not covered by the health system. Yeah.
I
Okay.
see. Thank you very much
Thank
for
you.
your
Thank you.
comments. Would there be any other comments? I think if like from Malaysia, if like might have more experience than us, so if someone can share some ideas, it might be very helpful for us too. Or not, okay. I think today we can end the lecture here. And lastly, I would like to appreciate it if you can fill out the questionnaire through the link in the chat. And thank you very much. And let's meet next week. Thank you and have a nice afternoon.